would be, what is the new normal? Do we freeze all or do we go in for fresh embryo transfer? So it's, as the picture clearly says, it's always a dilemma between the fresh versus frozen embryo transfer. Which option is better? Now, freeze all. What do we mean by freeze all? Freeze all, it says that cryopreservation of all mature oocytes or viable embryos after ovarian stimulation and embryo transfer in the subsequent cycle. As majority of our cycles are antagonist cycles, so this talk would practically hold for those cycles which are being stimulated by the GnRH antagonist stimulations. GnRH trigger is given. We freeze those embryos and transfer them in the next cycle. Now, what has led to the drift in practice towards frozen embryo transfer? It is because the vitrification techniques have developed so much that post-thaw survival rates are good and comparable implantation rates we get when we do the frozen versus fresh transfer. And moreover, there is an inevitable increase in the genetic screening where we need to freeze the embryos, as the result time to come for the report is roughly like 2 to 3 weeks. So we have to wait and we have to freeze those embryos, and so that we are able to transfer the healthy embryos in the next cycle. And there has been an improvement in the stimulation protocols, antagonist with agonist trigger, to have the OHSS free clinic. And then there are safe maternal and perinatal outcomes reported with the frozen embryo cycles. Now, what is the rationale behind the frozen embryo transfers? It is more physiological environment. It improves the embryo and the endometrium synchrony. There is no negative consequences of ovarian stimulation on endometrial receptivity. Moreover, because of this physiological environment, we are not giving any drugs. We are just following it naturally. So it also simultaneously has a positive impact on placentation and fetal growth. This slide, I took it from Sharda Jain's ma'am presentation. So again, this was the basis, like the frozen embryo transfer began its origin with to prevent the OHSS. Now what happens when we are doing a controlled ovarian stimulation? The hormone levels are very high. The supraphysiological levels are very high, and they cause the impaired endometrial receptivity. Along with that, with such high E2 levels, these patients are at increased risk of OHSS. So it began as a rescue strategy with PCOS and high responders. Now, this frozen embryo transfer, we take two situations. One is where it is unplanned. We call that as rescue or non-elective embryo transfer. And the second scenario is where we have already planned that it is going to be a frozen embryo transfer. Now the rescue, first point I have already covered, PCOS to prevent the OHSS risk. The other anomalies like uterine tubal anomalies, elevated progesterone, embryological reasons, we have to go in for a frozen embryo transfer. Now the scheduled embryo transfer, where we are doing the PGT, especially in cases of endometriosis, repeated IVF failure, and risk of thromboembolism. I'll just be touching each topic separately. So in cases of these untreatable uterine anomalies, they are usually discovered in 10 to 20% of the asymptomatic patients when we are doing the stimulation. Like hydrosalpinx, we all know that it is there in 10 to 30% of the infertile women. It decreases the implantation rate, the pregnancy rate, and increases the miscarriage rate. Endometrium polyps, submucous leiomyomas, if they are inadvertently or accidentally discovered during the ovarian stimulation, then we tend to freeze the embryos for them. Again, thin endometrium, we really had a good discussion that thin endometrium certainly decreases the clinical pregnancy rate and the live birth rate. And while stimulation, especially with the antagonist protocol, this protocol is known that on the day of trigger, we do find serum progesterone is high, especially when we are stimulating these patients with the recombinant FSH. So if there is an elevated serum progesterone, the variation and the cutoffs are different, but the majority of us, we accept it as 1.5 nanogram on the day of trigger. If the progesterone level is high, we prefer frozen embryo transfer. And the slow growing blastocyst. Now, if the instead of day 5, the good blastocysts are formed on day 6, we are already exposing the endometrium to 1 day extra progesterone, and hence it leads to suboptimal embryo endometrium synchrony and poor implantation rates. Now, as a scheduled or elective surgery, when we are awaiting the results for PGT for various reasons, endometriosis or adenomyosis related infertility, because the disease itself, it causes the structural and biochemical changes in the endometrium during stimulation, and women experiencing repeated IVF and ICSI failures, we prefer as a routine, as a strategy, as a scheduled frozen embryo transfer, because then we suspect that there could be an endometrium embryo asynchrony. Either we go in for ERA or we go for various other tests, and then we prefer the frozen embryo transfer. And women at substantial thromboembolic risk, because higher estradiol levels during stimulation, it causes the hypercoagulable state. So in those patients also, we prefer the frozen embryo transfer. And when we are doing the embryo pooling, especially in the poor responders. Now, this is a very beautiful article by Blockil et al. This is basically the SWOT analysis. The SWOT analysis basically is the strength, weakness, opportunities, and threats. I just would be taking all these points in detail one by one. Now, let's look at the strengths. We have already covered this point that it decreases the risk of OHSS. There's a better pregnancy rate, especially with the agonist trigger, which causes potential luteal support defect in fresh embryo transfer. There is a proven role of frozen embryo transfer that it decreases the rate of ectopic pregnancy. Better obstetric and neonatal outcome for children born after frozen embryo transfer, especially we see the increased risk of preterm birth, low birth weight, small for gestational age, and increased perinatal mortality associated with all these prematurity and low birth weight. With the fresh transfers, they are counterbalanced. And the abnormal hormonal milieu and the suboptimal endometrium development in conventional ovarian stimulation cycle, it reduces the risk factor for these adverse outcomes and is corrected. Now, what are the weaknesses? The weaknesses is that these benefits, they are verified in few small and heterogeneous studies. These RCTs are restricted mostly to the higher responders, and OHSS is not completely avoidable. There has been 6 RCTs, 4478 women. However, it's a low quality evidence that if the OHSS rate is 3% following the conventional strategy, it is 1% for the freeze-all strategy. This figure 5 is the forest plot showing the OHSS incidence in the frozen versus fresh. It favors the freeze-all, but the absolute risk is not 0. Even in the frozen embryo transfers, maybe because we heard that either we are giving the letrozole or tamoxifen, we do see some ovarian stimulation in those cases where it might lead to OHSS even in the frozen embryo transfers. Now, what are the opportunities if we are doing the frozen embryo transfer? Now, normally when we are doing the fresh embryo transfer, we normally give the stimulation either 10 days and 12 days. When the standard, like the thumb rule, when 3 or 4 follicles are more than 17 to 18 millimeter, we normally give the trigger injection. But when we are doing a frozen embryo transfer, we are not that worried and we are not that rigid. We do extend and we do prolong the stimulation so that we do get the more mature oocytes, which really helps, especially in cases of poor responders. Again, The hormonal cyclic monitoring, it becomes less crucial, because as we took the progesterone level 1.5 nanogram and we were freezing, then this is an opportunity in those conditions where where the progesterone level is high, we can freeze them. And then avoidance of oocyte retrievals during weekend days without the need of either oral contraceptives or estradiol valerate pre-treatment. Random start stimulation is possible, and it is more patient friendly, as we can also give the progesterone prime ovarian stimulation instead of injectable antagonists to prevent the LH surge. Now let us see what are the threats associated with the frozen embryo transfer if we follow this policy as a universal policy. By having gone through the literature, we all know now that there is an increased risk of adverse perinatal outcome in frozen embryo transfer, hypertensive disorders of pregnancy. There is a 1.3-fold increased risk, eclampsia 1.8-fold increased risk. The increased dosage of estrogens and progesterones used during the FET cycles, it causes the faulty invasion of the trophoblast into the maternal spiral arterioles. Moreover, the absent corpus luteum vasoactive products such as relaxin, vascular endothelial growth factor, and angiogenic metabolites of the estrogen, it predisposes to hypertensive disorders. The large for gestational age babies, seen more with the freezing, thawing, or extended culture, it leads to epigenetic alterations at the early embryonic stage. High birth weight babies, they may lead to stillbirth, asphyxia, shoulder dystocia, and hypoglycemia. There is definitely additional cost and extra workload on the lab. And see, it's a controversy. The patient is coming because the patients, they want to conceive early, and while we are doing the frozen embryo transfer, we are delaying the treatment. We are after freezing, we give a frozen time, and then we are doing it in the next cycle. So it's doing the reverse. So delay in the treatment process. Patient look for treatment solutions that minimize their time to pregnancy. Optimal vitrification systems of the lab should be considered before we take this as a universal policy, and epigenetic changes to be discussed. Now let us see at the Cochrane based data. What did the Cochrane suggested? This was a Cochrane database of 2021 by Zat T et al., where they compared the 3876 patients in the freeze all, and they took 3890 patients in the conventional IVF, and they compared the live birth rate after the first transfer cycle. Now certainly this is a forest plot. If you see it clearly, there's a very marginal difference, but yes, it does favors the freeze all policy for the embryo transfer. Now going further, when that was for the live birth rate after the one transfer, but when we take the cumulative live birth rate, there was absolutely no difference in the cumulative live birth rate. 8 studies were included. 3 studies considered the comparison for cleavage stage day 3 transfer, and these 5 studies, they compared the data for the blastocyst transfer. So in nutshell, the Cochrane proved that after the first embryo transfer, live birth rate may be marginally increased, but cumulative live birth rate doesn't increase, and that is what we look at it on a larger analysis. So why there was so much of bias? Because these studies that were included in the Cochrane, there were like 8 studies included. Out of that, like you see this study by Chen et al., PCOS patients, again study by the Shapiro et al. In normal responders, again third study by the same author, Shapiro et al., is again in higher responders. Again, this was by the Diamond V et al. This was also again in an ovulatory women. So all these studies, out of 8, the 4 studies, they did mention about the increased pregnancy rate or live birth rate in freeze all strategy after the first transfer. However, there was no account of the number of the embryos that were thawed or transferred, and majority of these patients, you see, these 4 studies led to the bias towards the freeze all policy, because these were the good prognosis patients, and as it is, it's proven beyond doubt that PCOS patients, we all go for freeze-in cycle. So the controversy is for the natural and the normal responders, and not the higher and the PCOS patients. So these 4 studies has led to so much of bias of the Cochrane opinion. So what lessons did we learn from the Cochrane? That there was no difference in the cumulative live birth rate of 58% in fresh versus 57 to 63% in freeze all group. OHSS decreased, I have already shown in my previous cycle, but not 0, 1 versus 3%. Time interval, they could not analyze, but yes, it was a shorter using a conventional IVF and ICSI strategy. Maternal hypertensive disorders, large for gestational age, higher birth weight of the children increased after freeze-all strategy, and there was a decrease in the ectopic pregnancy rate. It was uncertain whether the freeze-all, does it reduce the miscarriage rate, multiple pregnancy rate, or small for gestational age. And risk of hypertensive disorders certainly increases after the cryopreserved embryos. So they concluded that one strategy is probably not superior to the other in terms of cumulative live birth rates on the ongoing pregnancy rates. This was another major meta-analysis by Rook et al., who took 11 studies, 5379 patients. Again, the conclusion was, and the bias came because of the larger number of PCOS patients included in this meta-analysis. You see, these higher responders again led to a drift towards the bias, because 2035 patients were included by the Rook et al. Himself and by the Chen et al., which I have also shown in my previous slides. So in this Rook et al. Also, there were inherent biases, and there was no accountability of cases that did not reach a statistically follicular development and resulted in cancellation of the cycles prior to oocyte retrieval. There was no accountability of oocyte retrieval where it was unsuccessful, no accountability, and these were not taken into account where no embryos were available for the transfer, and the survival rate of the vitrified blastocysts, which did not survive. So this Rook et al., what lessons did we learn again? That there is an increased live birth rate in elective frozen transfer versus frozen versus fresh in the overall IVF ICSI population, but the subgroup analysis showed that higher live birth rate were more in the hyper responders, and there was no difference in the live birth rate in the normal responders. And same conclusion, that cumulative live birth rate did not differ in the overall population. And there was a decreased risk of moderate and OHSS, albeit at the expense of an increased risk of preeclampsia. So the take-home message from this talk is that it is too premature to apply the freeze-all policy to all ART cycles. No doubt, definitely we all prefer, and that's not a debatable question, that higher responders and PCOS patients, we do prefer freeze, but for the normal responders, it is too early. We do need well-designed clinical trials are mandatory. And if we have to shift our practice to elective frozen transfer, it needs to be tailor-made in individual patient circumstances, which includes you need to consider which ovarian stimulation protocol you have used. What is the method of trigger? Like if we are giving a dual trigger, or if we are giving an agonist trigger, and if our serum progesterone is high, then preferably we will prefer the frozen embryo transfer. Now, the day of embryo transfer and the day of freezing, whether we are doing a day 3 or a day 5. So, we have to individualize the approach according to the laboratory success rate. Also, that's a very, very vital factor to consider. What is the vitrification success rate of a particular lab before we take and make this as a universal policy? The vitrification process, the endometrium preparation technique, and the endocrine profile on the day of trigger. So I think we have to be selective and not universal. So with this, I end up my talk and I stop sharing.
Wonderful.
Thank you.
Wonderful.
Thank you so much, ma'am.
Yeah, wonderful presentation, Shalini. You very nicely explained about the indications where we should go for the frozen embryo transfer cycles. And I think FET cycle is not fit for everyone. We should judiciously decide which patient to be taken for frozen embryo transfer cycles and which to be taken for the fresh embryo transfer cycle. So the indications I will not repeat. You have very nicely mentioned about them. Which patients should be taken for the FET cycles. Thank you very much.
Thanks, Dr. Ila. R.K. sir or Dr.
Dr.
Pikee?
Shalini, excellent talk.
Thank
Dr.
you so much.
Shalini, excellent talk. I congratulate you for doing a very thorough research. And as you showed, the data is still skewed, and the majority of the patients are high responders. So you've very nicely given the SWOT analysis and given us the pros and cons. So I think the take-home message that you have given is very right. We have to tailor seeing the patient's profile and our lab, the vitrification facilities and outcome. So I think you've covered all the points. Very nice talk.
Is Dr. Jyoti Bali there? She was also the chairperson, but I think she had said that she would be busy with another meeting. Dr. Jyoti, are you there?
She's not there.
I think she's not there.
Let,
Okay.
Dr. Sharma, please make a comment.
Yeah, actually, it was an excellent lecture, and she rightly brought out, that one has to be selective in which patients we are going to do the freeze all and in which we are going to do the fresh embryo transfer. And secondly, important point she brought out, is that with the frozen embryo transfer, there is a chances of, having PIH. Though you are preventing OHSS, but the chances of, PIH is more in these patients. And the most important thing is the epigenetics. Now, that is, I think, as the research would come in, and then we'll know, how the epigenetics are being affected by this vitrification and freezing. Now, that may cause a paradigm shift in our thinking, whether we should do things all or we should do relatively much more, post transfers. There is a evidence over there. And now another important point you brought out was, the vitrification process and largest role into that. Because as a clinician, most of us may not see the embryos before they are being transferred. So I think
हाँ जी सिस्टर हाँ
we should see the
केड़ा
embryos
पेशेंट
before we transfer, so that we know
किधर देखना
how's the vitrification system going on in the laboratory, so that we can give optimized results. So when we keep all these things factors in,
Sorry, sir, just interrupting. Dr. Sidhu, please mute yourself. It's disturbing the session. Dr. Sidhu?
हाँ
Dr.
मैम
Sidhu?
just doing it just
Sure.
just doing it
Yeah, sir, carry on.
yeah. So basically, it is a good strategy, but we have to be selective, and then we should also counsel the patients regarding OHSS versus PIH, and also that there can be epigenetic issues later on, and maybe not in the first generation, maybe in the second generation. So that the time only can tell. But definitely the freeze facilities, the vitrification has made life much easier for the embryologists, for the clinicians, and to the patients, especially in sort of preventing the ovarian hyperstimulation. So keeping that in mind, we should be selective, and we should ensure the quality control in our laboratory. And then we should always be lookout of any defect in our the baby. So you should as a clinician follow up our IVF babies for a longer time. So normally what we do in our center is that yearly we have a meeting. We invite all the as many people those who have given birth after the IVF, so that we can see if there is anything so over the years, what I have seen, I do not know whether the IVF caused that, or